Hey everybody, welcome back to our continuing discussion of neurochemical signaling. This time we're talking about the pharmacology of the synapse and plasticity. Okay, so let's start off by talking about pharmacology that can happen at the synapse and specifically how it does that. Every little box you see here is a different way that drugs can potentially influence the way that neurochemical signaling takes place. So we've talked all about how neurochemical signaling normally happens. Now let's talk through some ways that drugs can alter that process. So the first thing we're going to talk about is drugs serving as a neurotransmitter precursor. So neurotransmitters go through a biosynthesis pathway in which they are converted from precursors into eventually a neurotransmitter through a number of steps that depends on which neurotransmitter system we're talking about. If a drug acts as a precursor, it makes, basically there's more available to be converted into a neurotransmitter. So it can increase the amount of that neurotransmitter that is available and can be released. An example of this would be something like L-DOPA, which is a precursor for dopamine that's administered to a Parkinson's patient. So the other side of this, it would be a drug that inhibits neurotransmitter synthesis. Right? For example, interfering with the process of this enzyme here that would prevent the conversion of the precursor into the neurotransmitter. So a drug that inhibits neurotransmitter synthesis would decrease the amount of neurotransmitter that's available, so less of it gets packaged into vesicles and released. So it will decrease the signaling strength of that neurotransmitter. So for box number 3, we have drugs that prevent the storage of neurotransmitters into vesicles. So if the neurotransmitter can't be packaged into a vesicle in the synapse, there's no way for it to be released, or at least no normal way for it to be released. So if neurotransmitters aren't packaged into the vesicles, then they won't be released when the calcium comes in and the vesicles fuse. If vesicles are empty, no neurotransmitter release. Conversely, a drug could actually facilitate neurotransmitter release from vesicles. Right? If that process is facilitated, we're going to have more neurotransmitters released into the synapse. At the same time, we can have drugs that will inhibit the release of a neurotransmitter, meaning we'll have less released. So, for example, if you're bitten by a black widow spider, that venom causes the affected neurons to undergo a more rapid vesicular exocytosis, thus dumping all of our neurotransmitters out into the synapse, which is where it gets all of its deleterious effects. By contrast, botulinum toxin, the toxin that causes botulism poisoning, does the opposite. It actually prevents, particularly acetylcholine in the neuromuscular junction, vesicles from binding and releasing the neurotransmitters. So botulism poisoning causes paralysis by preventing the release of a neurotransmitter from the vesicles. So both of those toxins work in sort of opposite directions on a vesicular release. So of course, drugs can work at the receptor. We've talked about all the different ways this can work. Drugs can stimulate the postsynaptic receptors, which we would call receptor agonists. And they can also block postsynaptic receptors, which we would call receptor antagonists. And remember, there are a lot of different ways that drugs can interact with the receptors. We talked about both direct and indirect agonism and antagonism. Remember, we talked about allosteric modulation. We also talked about partial and inverse agonists. So there's a lot of ways that drugs can interact with the receptor itself. So likewise, we can have effects at the autoreceptor. If a drug stimulates the autoreceptor, it's going to cause a decrease in the release of neurotransmitters. Remember, we talked about autoreceptors. Basically, they respond to the neurotransmitter that the neuron is releasing. So if we have a drug that binds to that specific receptor subtype, it will mimic the effect, right, and cause a decrease in neurotransmitter release. Likewise, we can have a drug that blocks autoreceptors, that sort of gets in here and blocks binding at that autoreceptor. And that's going to cause an increase in the release of neurotransmitters, right? Because if stimulating an autoreceptor causes a decrease in neurotransmitter production, if you block the autoreceptor and prevent it from acting normally, the normal feedback mechanism from neurotransmitters released from that releasing neuron can't act. So it's going to increase the release of neurotransmitters. So next we talked about the process of enzymatic degradation, enzymes that come along and sort of take apart active neurotransmitters in the synapse. That halts their signal, right? Once an enzyme degrades a neurotransmitter, it's not going to be binding and doing its thing anymore. If a drug inhibits these enzymes that are normally degrading them, we're going to have more of that neurotransmitter available. So an example of this is physostigmine, which acts on acetylcholinesterase. Acetylcholinesterase is what deactivates acetylcholine. So if you administer acetylcholinesterase inhibitor like physostigmine, it's going to increase the amount of neurotransmitter that's available in the synapse. So there exists a plant toxin called curare that will competitively bind with nicotinic acetylcholine receptors that are happening in our neuromuscular junctions. So those receptors are really important for voluntary movement of our muscular system. So curare poisoning causes paralysis by preventing acetylcholine from binding with those receptors. We could use something like physostigmine, acetylcholinesterase inhibitor, to treat poisoning with this, because it will block the action of acetylcholinesterase, which normally degrades acetylcholine. And if we do that, we increase the amount of acetylcholine that's available, which can then compete with curare and bind and restore function. Finally, drugs can block reuptake. Right? Normally, especially with small molecule neurotransmitters, they are taken up out of the synapse into the releasing neuron, or perhaps a different neuron or an astrocyte after they have done their thing. So what a reuptake inhibiting drug can do is block that process. So that way when drugs bind, they aren't taken back up right away. They sort of can't get back through this channel and continue to stay out and do their thing. Common example of this would be a selective serotonin reuptake inhibitor, or an SSRI. Those elevate serotonin concentrations by preventing their reuptake. I also wanted to mention the concept of synaptic plasticity. We've touched about this already, talking about dendritic spines and how dendritic spines can change in size and shape, as well as the density of proteins that are bound to the membranes in a synapse as a result of a number of different things. Neural changes can take place from sensory and environment, exposure to new things in your environment, learning, drugs, experiences of many kinds, stress, for example. This can result in changes in strength, the creation of new synapses, terminal growth, changes in spines, etc. Generally speaking, this doesn't mean new neurons showing up and making new connections. With rare exceptions, there's not really neurogenesis in the adult brain, with the exceptions of dentate gyrus and the hippocampus and the subgranular zone, which is part of your olfactory system. Otherwise, we're just talking about changes in neurons that exist already, what they're connected to, and the nature of those connections. Since we've been talking so much about protein kinases this chapter, let's talk briefly here about mitogen-activated protein kinase, MAPK system. This is just a really, really important signaling pathway for a lot of these synaptic plasticity mechanisms. It's downstream of a lot. It's kind of too big of a thing to talk about exactly all of the stuff it's involved in. It's important because it's so widely. Something else that's gotten a lot of interest in, I guess, the past few decades is synaptic modulation by ERK, which is an element of the MAPK pathway. So this signaling pathway, the one that involves ERK, is especially important for memory. So a lot of the time, the MAPK system is related to things like cell growth and differentiation, and is triggered by that sort of thing. But it's worth mentioning that the ERK pathway is, I guess I should define what this is, right? Extracellular signal-related kinase is ERK. The reason we're mentioning this is it's basically a means for extracellular signal stuff, so synaptic transmission, to activate this MAPK pathway, and the MAPK pathway often leads to the phosphorylation of things like transcription factors, which can alter gene expression in a number of different ways. Again, that might sound very non-specific, but we're speaking pretty generally about it. It's important for a lot of things like cell differentiation and growth, but for those of us in the learning and memory realm, we are interested in this pathway because it's so important for learning and memory. So I'll show a graph of this on the next slide here, but spines are initially pruned, so we start with a lot of spines and a lot of connection, but these are pruned as a sort of function of experience, but they retain their plasticity, so spines can grow and change as a function of experience or lack of experience. So here we have kind of just a generalized graph of the number of dendritic spines that are present across different development periods. So you can see here in blue we have a normal individual, a normal healthy individual, who shows formation of spines during prenatal period, spine development happening during birth, and then sort of a peak in the number of spines present during childhood, which decline throughout adolescence, are maintained through adulthood, and begin to decline in late adulthood. And you can see here a number of neurodegenerative diseases or other neurological disorders such as Alzheimer's, Parkinson's disease, and Huntington's disease, show a similar pattern, but increased spine degradation in late adulthood, whereas those with autism spectrum disorder show an elevated level of spines throughout the adult lifetime. Okay, that's it for this little mini lecture. Next we are on to the endocrine system.